Good morning and welcome to the Fight CRC webinar. We will be beginning shortly. I want to introduce myself. My name is Julie Kraus. I am a rat with Fight CRC. I have been a rat since 2016. Today we're going to go over what was presented at ASCO, and we're very fortunate to have Dr. Cannon with today, who's going to give us a recap of everything ASCO. I was there personally. It was a really neat experience. It was very nice to be back in person, I have to say. So today, if you have any questions, please leave them in the Q&A section. You're very welcome to add chat messages across the right-hand side of your screen. Little information here. The information and services provided by Fight Colorectal Cancer are for general information purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnosis, or treatment. If you are ill or suspect that you are ill, see a doctor immediately. In an emergency, call 911 or go to your nearest emergency room. Fight Colorectal Cancer never recommends or endorses any specific physicians, products, treatments for any conditions. At this time, I'd like to introduce Dr. Timothy Cannon. He is a medical oncologist at Inova Health Cancer Institute that focuses on gastrointestinal malignancies. He is an associate professor at the University of Virginia Medical School and has been the director of Inova Molecular Tumor Board since its inception in 2016. He serves on multiple national committees and is currently the steering committee chair of ASCO's multi-basket taper trial. His research focuses on novel therapies for colorectal cancer. We welcome you today, Dr. Cannon.
Thank you, Julie. All right. Well, thank you, everybody. I'm excited to be here. I thought it might be helpful just first to describe, what ASCO is like, because I'm charged with telling you about the colorectal cancer highlights from ASCO. But it might be helpful to know the scope of this meeting. It is a huge meeting with thousands, even tens of thousands of attendees. And there were over 2,000 posters overall presented, with hundreds of colorectal cancer posters presented. There were also multiple presentations. But I've tried to distill this into a digestible amount, excuse me, into a digestible amount today and give you the highlights as I see it. Luckily, I have the help of the ASCO committee, which chooses the most important abstracts, or in their view, or they vote on the most important abstracts and put those in different special sessions called the oral abstract session, the poster presentation session, and also this time there was a special late-breaking abstract session. And that's what I'm going to start with, was the kind of the biggest piece of news that you probably saw come out of ASCO. It was reported on the nightly news of most major networks, and it's resulted in dozens of calls to our office this week. And that is the rectal cancer trial for MSI high patients that was reported after the first 12 patients had a complete clinical response without surgery. So to give a little background here, this was a study done at Memorial Sloan Kettering in New York, and they were testing the hypothesis that patients with a certain genetic subtype of rectal cancer could receive immunotherapy and perhaps not need to go and get surgery thereafter and not require chemotherapy. And they used a PD-1 inhibitor called dostarlimab, which is the same class of medication that nivolumab and pembrolizumab are. These are very common medicines used today. And it has really the same mechanism of action and is similar to those medications. But they identified patients very early who had microsatellite instability or mismatch repair deficiency. That means that whenever there's a mismatch in DNA, most of us have the tools to repair that DNA efficiently, but people who have a genetic mutation in one of the genes that controls the proteins that are our tools for repairing mismatch repair or if they have a condition that silences the DNA transcription of those genes, they end up being unable to repair mismatches and being prone to colon cancer. And that group of people, that small subset of people, which represents 15% of all colon cancer and 6.7% of rectal cancers, tend to respond much better to immunotherapy. And so the researchers at Sloan Kettering said, let's see, what happens if we give this drug to people who have stage 2 or 3 rectal cancer. And this is especially pertinent to the people with low rectal cancers for whom surgery would require a permanent ostomy bag. I said, let's see what happens if we give this drug and see what their response is and how it impacts their outcome. And remarkably, the first 12 patients enrolled in this trial all had their tumors completely disappear. In other words, when they did the endoscopy and MRIs, they didn't see any more cancer. And they all had a complete clinical response without surgery. So with these amazing results, they said, let's report these results before the trial's even finished or hit a predefined endpoint, and report it at ASCO. And so they did this late-breaking abstract that was presented Sunday morning, where they reported these 12 patients all having a complete response. And it was subsequently reported in the news. And oncologists all over the world are now getting phone calls about how their patients can get this drug and whether they have MSI high. And I think that's a good thing to improve, to sort of get all this excitement about using immunotherapy in rectal cancer. So the significance of this trial is this suggests that most rectal cancer patients with microsatellite instability will be able to watch and wait rather than go to immediate surgery if they're treated with immunotherapy. The second point is, if the durability, in other words, if this response is as good as we've seen with chemotherapy responses when people have a complete response, in other words, if it lasts as long as it has with other modalities, so if the durability of response mirrors that which we have seen with chemoradiation in patients who have a complete response, the majority of the patients probably will never need surgery in this trial, meaning no lifelong ostomy bag. It demonstrates a uniquely high clinical complete remission rate for dostarlimab in this population. On the right here, I put a few reasons to moderate enthusiasm. This is only relevant for about 6 to 7% of rectal cancers. The second point would be that the clinical complete response is not the same as a cure, and longer term follow-up is needed. It is likely that some of the patients will relapse, but I'm not sure about that. The third point is, I think I and most oncologists see this as a triumph of process and patient selection rather than a clear demonstration that this particular drug is uniquely superior. In other words, it's amazing and great that Sloan Kettering was able to very quickly determine who the patients were that were MSI high and who might respond to immunotherapy and start this treatment before the patients had surgery or chemotherapy. But ultimately, it is possible that other older PD-1 inhibitors might give it the same results, but we don't know that yet. There may be something uniquely superior about the drug as well. All right, so I'm going to move on to, from that trial, we're going to pause at the halfway point. If any of you have questions about this particular trial, it might be best to write it down and we can discuss them when we get to the halfway point. But I'm going to go through a few other abstracts before we take that pause. And I'm going to do that by topic. And I think since we started with this late-breaking abstract, I'm going to just briefly overview 3 abstracts that were related to the topic of how more people can treat rectal cancer without surgery. So the first trial was a trial that looked at early-stage rectal cancer and compared 2 different ways of treating it. One was the more traditional way, where you do a full resection of the colon, cutting all the way around the tumor and cutting out the entire mesorectal envelope that contains all of the lymph nodes, and then retying the colon together, or if it's too low to do that and too close to the sphincter, doing a surgery that results in an ostomy bag called an APR. So of course, traditionally we've thought the bigger surgery is better because we dissect out the lymph nodes and it's more likely to be curative. But of course, there's a movement towards an emphasis on trying to do less surgery to get the same result. So this trial compared doing an upfront traditional surgery to doing chemoradiation upfront, and then trying to do a resection through the endoscope. In other words, not doing a full thickness resection, but rather going in with the sigmoidoscope, going into the colon and kind of snipping it out that way, or even not doing surgery at all if it appears to be all gone. So the advantage of the TME, which is the total mesorectal excision, cutting a segment of the colon out and retying things, is that you get to dissect out all the local lymph nodes where the cancer may have spread. The disadvantage, of course, is the morbidity of the surgery and the long-term bowel changes, as well as the possibility or likelihood of the person going through the surgery having a permanent ostomy. So in this first study on the left, they compared, like I said, the full surgery with chemoradiation and a lesser surgery. And the question was, is it just as good? And the answer is, we can't answer that yet. But of the people who had the chemoradiation arm, 45% of them had a complete remission of their tumor without doing any surgery at all. The study also showed that people who didn't do the full surgery, but did the chemoradiation and a less invasive surgery thereafter, had less hospitalizations and complications. However, the last point here is important, and that is that in the group that had the full thickness surgery, the TME, 21% of them ended up having node positive disease. And that 21% of people are the people we're concerned about, because if they had had chemoradiation and then a small endoscopic surgery or no surgery at all, we would never know that those lymph nodes have cancer cells in them. Going to a second abstract related to this was the Star Trek trial, a very interesting 3-arm trial that compared organ preservation type treatments, again, chemoradiation followed by as little surgery as possible or no surgery, and 80 patients were in those arms. It was actually divided in half, where 40 in the organ preservation arm, that means preserving the sphincter and not cutting through, not doing a major surgery. 40 of them got one radiation schedule, another 40 got a different radiation schedule, but there were 80 of them overall. And they were compared to 40 patients who just had traditional surgery up front with a segmental colon resection. The study was actually designed so that the primary question answer to the primary endpoint was, is it feasible to recruit to a study like this where you randomize people to different surgery methods? Remember, that is a hard sell when you're talking to a patient and say, we're going to tell you and choose for you which of these strategies you're going to do, and you just have to accept whichever arm you're randomized into. And my own feeling would be that, different countries have different, socialization and cultures around healthcare, and that this may be easier in some countries than in the United States. And this particular study was done in Europe. But in any case, they did discover that it was feasible. And then their secondary endpoint, which is probably what more patients are interested in, was the non-regrowth disease-free survival any different between the two arms? And fascinatingly, if that's a word, or what I found was fascinating, was that the non-relapse disease-free survival was 90% in the people who did the organ preservation type strategies, and was 86% in the people who had a full thickness big surgery. Furthermore, 60% of the people who were in the organ preservation arm actually did achieve the goal of organ preservation. Of course, many of these, after they did chemoradiation, were discovered clearly not to be candidates for a lesser surgery, and they ended up having to get the surgery anyway. I'm sure most of you watching at home are thinking, well, why wouldn't we try that with everybody? And the truth is, there is a little danger in that, right? As we're watching and looking with MRIs and endoscopies, there always is the potential the cancer could be spreading to the lungs as we're watching. And but for 60% of people, they were able to either get a lesser surgery that didn't require a permanentostomy or no surgery at all. So though this trial was not set up to have non-regrowth disease-free survival or organ preservation as the primary endpoint, the results are good enough that it does allow us to wonder whether chemoradiation followed by waiting or endoscopic resection can avoid surgery and lead to comparable outcomes in most patients. One more question we have here as oncologists is, when we do this watch and wait type of strategy, we all get very nervous that the cancer is going to spread to other organs while we're doing our watching and waiting. How do we better predict who's going to benefit from this strategy? And how do we predict who really should get surgery? And I thought this was a very interesting study that used something called the immunoscore to stratify people based on their risk of recurrence. An immunoscore is an estimate of the likelihood of recurrence based on the type of immune cells that are surrounding the tumor in the microenvironment of the cancer. When people have a high number of activated CD8 positive T cells and they tend to have a better prognosis. And the T cell milieu around the tumor helps us know a little bit about how likely it is to recur at some point. And indeed, in this study, the people who had the best immunoscores had a 5-year recurrence-free survival rate of 97% with the watch and wait strategy. Those with intermediate scores were 61% and low scores were 55% respectively. So the question is there a way to predict who will not have a recurrence with a watch and wait strategy? And the answer is, well, of course, not perfectly, but yes, basically there is a good way to stratify with the immunoscore based on these results. Okay. Lastly, before we stop for questions, I just want to present the optical study. We've been speaking about rectal cancer exclusively to this point. And in rectal cancer, which sits in the pelvis near a lot of muscles, the bladder, the prostate, the gynecological organs, there's a lot of places the cancer can advance to locally and spread to, whereas the colon kind of is a hollow viscus sitting in the middle of the abdomen. And so radiation has never been thought, preoperative radiation has never been thought to be useful in colon and hasn't been in clinical trials, but has been useful in rectal cancers. We've moved towards doing chemotherapy also before surgery for many, if not most of our rectal cancer patients now, but we don't do that for colon patients. Of course, the rectum is the bottom 15 centimeters or so of the colon. And there was a study in China that asked about giving chemotherapy first before surgery in colon cancer, which is not a standard of care. The question they asked was, does doing chemotherapy before surgery improve disease-free survival in T3 and T4 colon cancer, not rectal cancer? And the answer is this was not proven by the optical study. The 3-year disease-free survival rate was 79% in the chemotherapy first arm and 77% in the surgery first arm. That was not considered statistically significant. The 3-year overall survival was 95% in the preoperative chemotherapy group, which is very good, but it was 89% in the standard of care group. And that difference was not statistically significant either, although somewhat interesting. A post-hoc analysis revealed that when females received chemotherapy first, there was a disease-free survival. But again, you have to be careful about reading into that too much when the trial was not designed to answer that question. All right, so we've spoken here so far about the best ways to treat rectal cancer and how little surgery you can get away with, and then the idea of giving preoperative treatment in colon cancer. I'm going to pause there before we go into before we get into the concepts about metastatic cancer and see if anyone has any questions.
All right, we have a question from Pam. Is the research now being focused on the other young onset colorectal patients that are MSS, MMRP, KRAS wild type? Any clinical trials with possible immunotherapy drugs for this tumor type? Thank you.
Yes, we are getting to that later in this presentation for colorectal cancer, for stage 4 colorectal cancer. In this ASCO, there were no major discoveries regarding the use of immunotherapy in MMR proficient rectal cancer, unfortunately. The low-hanging fruit right now is the MMR deficient tumors, and I think it is true that we're not making as many advances with the MMR proficient cancers, which of course represents 93% of rectal cancers. So that's an area we have to work on. Yes, there are a lot of studies going on that are exploring that, that question, but so far there hasn't been a lot of progress or any specific indication for preoperative immunotherapy in that group of patients.
Thank you, Dr. Cannon. And then we do have a question from Annie as well. How is high immunoscore related to MSI status?
Well, they're different tests, but it would be, it's likely that MSI high patients would have the best immunoscore, high immunoscore. And that's been looked at retrospectively. But the immunoscore test is really probably designed for patients that are not MSI high. If they're MSI high, we know they have a very immunogenic tumor, and that immunotherapy will probably be a part of their treatment. So this immunoscore is really useful for the other 93%. But it's not tied directly to the use of immunotherapy, and I guess that part is a little confusing. It's really more of a prognostic, more prognostic for patients doing the more typical MMR proficient, more typical rectal cancer treatment paradigm, which is chemotherapy, chemoradiation, and then surgery.
Thank you, Dr. Cannon. That's all the questions we have right now. So if you'd like to continue on, please do.
All right, so as far as metastatic cancer, I put a picture of a dishwasher here on the left because some of the concepts that came out of ASCO were about sort of the order in which you give the drugs. We always taught people that, taught students and residents and fellows that, it may not matter as much which order you give all of the chemotherapy drugs in, as long as the patient gets them all at some point. And the 2022 ASCO probably did not change the standard drugs used in stage 4 colon cancer, but there was a lot of information about the ideal order in which they could be given. I put the picture on the left because my wife and I always have an argument about how to do the dishes, and she insists on cleaning everything, really well before you put it in the dishwasher. My philosophy is, you just stick it in there, and whatever doesn't get cleaned, you run through again. Then you realize what you need to wipe off. And so that's been a sort of the order of events in dishwashing has been an area of contention at our house. And so I thought that was sort of a good metaphor for the questions that have come up in this ASCO about the best order to give these drugs in. The studies I'm about to show you strengthen the growing consensus, and this is important, that right and left-sided colorectal cancers should be treated as distinct diseases. We've known they're genetically different, they're unique, they have different prognoses and a different responses to therapy. And I truly do think of them as different diseases. And I think the information in ASCO from ASCO this year strengthens that belief. So the first one I want to show is the Paradigm trial. This simply asks the question of whether in patients who don't have a RAS mutation. Remember, a lot of you may know that you sort of, when you're talking about your colorectal cancer and you want to describe it, you usually say, am I MSI high or not? Am I RAS mutated or not? RAS wild type means not mutated, going back to Gregor Mendel and the plants at his monastery in Europe, with the pea pods. Wild type meant no, no mutation. And so for those with a RAS wild type, those who don't have a RAS mutation, is it better to give, is giving an EGFR antibody like cetuximab or panitumumab first instead of bevacizumab with first-line chemotherapy? Does that help patients live longer? And the answer is yes. Overall survival was better when people received panitumumab first. That was the difference was really in the left-sided colon cancers, and that was enough to account for the the statistically significant survival benefit in the entire population, but when you broke it down, it didn't really matter for right-sided. But for left-sided tumors, the median overall survival was 38 months versus 34 months if you gave the EGFR antibody first. Remember, bevacizumab is something that essentially prevents the tumor from building a blood supply through antibody inhibition of VEG, something called VEGF, vascular endothelial growth factor. So the response rate in left-sided tumors was 80% if they received panitumumab and a little over 68% if they received bevacizumab first. So for left-sided RAS wild-type tumors, adding panitumumab to the chemotherapy is better than bevacizumab. All right, second question, how to optimize the chemotherapy treatment of left-sided colon cancer. As far as how much chemo to give. So they compared giving 3 types of chemotherapy together with panitumumab with 2 types of chemotherapy with panitumumab. And this was a large Italian randomized trial with 435 patients. And the answer to the question was there was no significant difference in progression-free survival, early tumor shrinkage, depth of response, or successful surgery rate in either of the arms. But of course, there was much more toxicity when people got 3 chemotherapies. So the takeaway is that this suggests for this type of colon cancer, not every colon cancer, but for left-sided colon cancers, those below the splenic flexure below, for left-sided colorectal cancer without a RAS mutation, it seems better, it seems just as good to give 2 types of chemotherapy with panitumumab as 3 types. And certainly it's less toxic. And so that is my practice, and probably the practice now of most colorectal cancer oncologists. All right. Here's another relevant question to those RAS wild type left-sided colorectal cancers. Do you keep on giving chemotherapy indefinitely, or can you stop and wait for the cancer to grow again before you restart? This reminds me of interval training and running. I like to run. I've got a picture of, with their permission, 2 of my running buddies. I don't live in San Francisco, but this is part of a trip a long time ago. And they, one of them favors sort of that interval training where you run 2 miles, walk a mile, run 2 miles, while most of us favor just running as far as you can at once. Similarly, with chemotherapy, probably the more common way to do it up to now has been to just keep giving chemotherapy until the cancer progresses. Understandably, patients don't always want that, and they prefer breaks. And so this was the IMPROVE study evaluated whether it might be feasible to give 16 weeks of chemotherapy and then stop and do CT scans every 2 to 3 months and wait until you see the cancer grow before you restart it again. This is a hard thing to measure success-wise because the trial will take a long time if you wait to see how long everybody lives, because people with left-sided RAS wild-type colorectal cancer live an awful long time, even when it's metastatic. So the primary endpoint was progression-free survival on treatment. That means how long during treatment did they go without the cancer progressing? In other words, for person A, they're just getting chemo on, and you're just measuring when the cancer progresses. But for cancer B, they're getting it, or for patient B, in arm B, they're getting the chemotherapy for 16 weeks, then they're stopping, then they're getting it again. And so you count those 16 weeks and you don't start counting again until they restart. And then you see how many weeks on treatment it was until they actually progressed well on treatment. And so that by that measure, the progression-free survival on treatment was longer if people stopped and then restarted. And the question is, does this change practice? And I can say it doesn't, not definitively, due to the nature of this endpoint. This is a strange way to measure success in a trial, and it kind of leaves us wondering, if this is really a better strategy. But it does, at the very least, make me consider doing this. These are very interesting results, and I love the idea of sort of having an endpoint to your treatment and letting that patient go and live a lot of their life without treatment. So I find this treatment paradigm very attractive, and therefore I found this to be a very illuminating study. All right, now I've just presented 3 abstracts that were about left-sided RAS wild type cancers, which of all colon cancers, unfortunately, that's less than half of them. What about the rest? You know, the right-sided colon cancers, or the ones that have a RAS mutation or a BRAF mutation. I consider this group the high-risk type colorectal cancers. And although many in this group can have a good outcome, you know, statistically, their outcomes are not as good as the left-sided RAS wild type cancers. So for this higher risk group with RAS mutations, BRAF mutations, and or right-sided tumors, we're going to ask the same question we asked before. Is 3 better than 2? And so the phase 3 Cairo study was designed to answer this question. And in this population, it appears that 3 chemotherapies are better than 2 by the measures, by the endpoints the study was designed to measure. The progression-free survival was longer in the group that got 3 types of chemotherapy. The response rate was higher. And ultimately, the successful surgical rate was higher. It's a hard thing to measure because everyone's tumors are so different. But in general, the results all seem to favor the 3-drug chemotherapy with bevacizumab. So the interpretation was, for the higher risk colon cancer population, FOLFIRINOX has a better progression-free survival and response rate and a better chance for resection, albeit with more toxicity. So summary about what we learned about first-line treatment of metastatic colorectal cancer. Right and left-sided colorectal cancer should be treated as distinct disease entities, as should RAS mutated and RAS wild type. For first-line treatment for left-sided colorectal treatments without RAS or RAF mutations, FOLFOX, 2 drugs, at least as good as 3, it looks like. And that you could consider intermittent rather than continuous chemotherapy. Meanwhile, for the rest of us, right-sided colorectal cancers or those with RAS mutations, 3 drugs may be better if clinically appropriate, and it's probably only clinically appropriate for patients that are in good enough shape to receive heavy chemotherapy. All right, one last study before I pause again. People always ask me, patients always ask if they have widely metastatic disease, should I remove this primary tumor in the colon? I think they envision sort of this mothership type of biology where everything's feeding off that primary tumor where it started, and wonder if it's better to remove this primary tumor, or is it better to start with chemotherapy, put a picture of weed killer, because I always use the analogy of flowers and seeds. Is it useful to pick the weed, or is it better just to focus on the weed killer? An abstract LBA 3507 addressed this study. It was a German study with nearly 400 patients randomized to surgery or chemotherapy. Again, my feeling is this would be a little tough to do in the United States, but they were able to successfully randomize patients and tell them whether they were going to do surgery or not. And the answer was that removing the primary tumor did not improve outcomes. Now, the caveat is this study was only designed to study whether surgery before chemotherapy improves outcomes. Of course, a lot of times you think about removing it in the middle of treatment or other times, but in general, I think it certainly increased the level of evidence that surgery, removing the primary when in clearly unresectable, in other words, in a patient with a lot of metastases, is not helpful. All right, I'm going to stop there for a second before I move on. Any questions about those studies about how to treat metastatic colorectal cancer?
Yes, we have a few questions that have come in.
Okay.
So this is from Catherine. Are there any doctors that deal with LARS after you have surgery?
Yeah, that's a great question. So LARS is low anterior resection syndrome. A lot of these studies I discussed with you are really all about avoiding the ostomy bag. And so patients really understand that they wouldn't, a lot of them would prefer not to have an ostomy bag. But I think what's sometimes underappreciated and gets to the point of this question is that even if you have a low anterior resection, which is the kind of surgery that's in the mid and upper rectum and allows you to tie the colon together or the rectum back together without a permanent ostomy bag, people aren't as afraid of that type of surgery, and partially with good reason, but there still is the risk of having Lars syndrome thereafter, which includes diarrhea and urgency and all sorts of symptoms. And I have to say that it is hard to find a specialist in that field, and this plagues a lot of our patients. Our colorectal surgeons are pretty good about following up with people and trying to determine best practices for dealing with the symptoms of this. But I don't know of, unfortunately, I don't know of a lot of people that just make this their research focus. And I do feel like it's an under-researched syndrome after surgery.
Thank you. We have a question from Julie. There is debate in patient groups on the implications of some of these studies, like the paradigm on the selection of pani versus you know what I'm talking about, since they aren't identical. Would you say implications are applicable for the EGFRI broadly or pani specific?
I do think they're broadly applicable. I don't think there's a big difference in the efficacy of panitumumab or cetuximab. Panitumumab came along later because it's fully humanized, and there's a lot of people that have allergic reactions to the mouse portion of cetuximab, particularly people below the Mason-Dixon line because of exposure. And I can't remember what the exposure is to, but there's a higher risk of allergic reaction if you grew up in Virginia or south of Virginia, south of DC. But and panitumumab is a fully humanized antibody, and so it doesn't have the allergic reactions. That's really the advantage of panitumumab. And the dose, it came out with a little more convenient dosing schedule, although you can do the same with cetuximab. I think of the two drugs as equivalent. There have been studies trying to see if you don't respond to one, will you respond to the other? And they've mostly shown no responses in that setting. So I think data about one agent is interchangeable with the other is the short answer.
Thank you. And then we have a question. What about right-sided wild-type tumors? Are they as high risk? Are they considered high risk?
Why is that?
What about right-sided wild-type tumors? Are they considered high risk?
So yeah, they still have had a worse, slightly worse on average. Remember, this is just a very general statement about average statistical averages, but on average, they have had lower survivals than left-sided tumors, even when RAS wild-type. And furthermore, in most studies, the use of EGFR antibodies have not been helpful in the right-sided RAS wild-type tumors. So that's why they're lumped in together with the RAS and RAF mutated tumors, is they don't seem to benefit from EGFR antibodies, and they do seem to have a worse prognosis on average. Remember, a lot of those patients still have great outcomes or are living for a long time, but on average, it's worse than the left-sided.
Thank you. And this is my question.
Yeah.
So once RAS mutant, always RAS mutant. So primary RAS mutant, would all my metastatic sites have been RAS mutant as well? They haven't been tested.
Yeah. Essentially, the answer to that is yes. Truncal mutations like RAS mutations will be found in all metastases, and I've never seen an exception to that. I did see a publication once on a case report, but of course we didn't know if that was just an error in sequencing. The opposite, however, is not true. Those who start off at RAS wild type very commonly become RAS mutated, which we'll discuss in a few future abstracts here.
Thank you.
And it's not, probably the more accurate way to say it is tumors are heterogeneous and they have a lot of genetic changes within. And among 1 million cancer cells, there may be some with RAS mutations that then emerge as you easily kill the RAS wild type tumors. That's evolution in high speed, which is kind of what happens with cancers, where the cells turn over fast and evolution occurs quickly. And there's a survival of the fittest cells. And sometimes those are the RAS mutant cells that you didn't know you had. So anyway, is that all? I'll keep moving on. And that gets into this liquid biopsy dynamics. I think because of time, I'm going to just very quickly just summarize the findings of Pursuit and Remarry and the concept, which is that if you've given an EGFR antibody, it's no longer working anymore, and what I do now and what a lot of people do now is we check liquid biopsies to see if a RAS mutation has emerged. And what we know from these studies is that if it hasn't emerged and you decide later on to retreat with panitumumab or cetuximab, the EGFR antibodies, you have a chance of a response. It's not a high chance. The response rate was 14% or so, but you have a chance of response. However, in these studies, in the rare people that had persistent RAS mutations, it essentially never worked to do that. Sometimes these RAS mutations will appear for a while and disappear. And what was important was what the status was at the time of treatment. But retreatment with an EGFR antibody after you've already progressed once in your past is occasionally helpful and maybe worth doing if there's not other options. Additionally, the time, this is from the MD Anderson study that looked at this, the time that has elapsed since your first recurrence, or the time that's elapsed since the last time you were treated with an EGFR antibody predicts for how likely you are to respond this time. So the person who just had cetuximab 4 months ago and now you try again has a very low chance of having success. The person who tries 2 years after their last dose of cetuximab seem much more likely to have a response. The MD Anderson trial also tried to give trametinib, a MEK inhibitor, because MEK, that pathway is a means of resistance to EGFR antibodies that emerges, and they thought giving a MEK inhibitor a pill might improve the outcomes, but in this case, it didn't in this MD Anderson trial. So the summary is retreatment may help. The longer you wait, the better. And it may be only worth trying if you haven't had a RAS mutation show up as a predictor of resistance on your liquid biopsy. All right, you were asking about immunotherapy. Oh, yes, checkmate 142. I want to go over this. This is for colorectal cancer. This includes colon cancer. This is just for MSI high. These are for people who get 2 types of immunotherapy, nivolumab and ipilimumab, a PD-1 inhibitor and a CTLA-4 inhibitor. Remember, dostarlimab is a PD-1 inhibitor. The rectal cancer data we showed you was for 1 drug. This is for 2 drugs for people with metastatic cancer, colorectal cancer. And the 5-year follow-up data was available at this ASCO. Remarkably, in this unique population of colorectal cancer, the amount of people with MSI high disease who received nivolumab and ipilimumab that didn't have any progression of their cancer 4 years after they started this treatment was over 50%. So that really stands out here, that over half the people who started this treatment 4 years later, their cancer still hadn't progressed. Obviously, everyone wants to know, well, how much longer will it last? And this treatment paradigm is a little too new to know that. I have no idea. Could it be decades or forever for some patients? Yes, but we don't know that yet. All right, what about for the rest of us, the 85% of colorectal cancers that are not MSI high? And this, I know all this MSI high talk is really frustrating to the rest of us, that aren't MSI high, the rest of the patients who aren't MSI high. So the question here was, does adding nivolumab and immunotherapy to chemotherapy improve response rates? This was not a randomized trial, so we don't really know the answer to that, but they thought anything above 75% would be, significantly better than historical controls. And indeed, in this trial, the response rate was 77%, which met the primary endpoint. Gives us hope that immunotherapy may be a part of treatment for everybody someday. And the other question is, in the MMR proficient patients, can immunotherapy combinations without chemotherapy induce responses in this MMR proficient colorectal cancer, the other 85%? And this was a hopeful study in that, yes, with in this group with ipilimumab and nivolumab, the 2-drug combination, there was a 30% response rate in this small phase 2 trial. How about novel therapies? What's new out there? Just because of time, I'm gonna roll through this here. So I picked, this is from the novel therapy section. These are all very early stage treatments. None of these trials were specific to colorectal cancer because they were just testing the safety of the drugs. But I picked out a couple of trials that I believe in the future may be of interest in colorectal cancer and have a chance to change the outlook in stage 4 cancer. One is a MEK1/2 inhibitor. MEK is part of the MAPK pathway and below RAS. So this has implications for RAS mutant cancers. Their RAS is always active and you can't turn it off. And which is why blocking EGFR signaling doesn't work. But MEK is downstream of RAS and has always been of interest as a target for RAS mutated colorectal cancer. And this MEK1/2 inhibitor showed that several treatment responses as a single agent, just giving it by itself, induced tumor response in patients that had an NF1 germline mutation, which is sort of upstream of MEK in the MAPK pathway as well. So actually, it's not a canonical part of the MAPK pathway, but it's involved in that signaling pathway. And so of the 16 patients they tested, all of them had some shrinkage. Again, this is in a very specific subset of molecularly defined patients, but it still hopefully will have implications for colon cancer because it's a new type of drug. It inhibits both the isoforms of MEK. CBP1008 is a bispecific ligand targeting FR alpha and TRPV6. This is a phase 1 trial. It was also well tolerated. 6 out of 18 partial responses were observed in the patients who were shown to have a high score for these receptors. So I thought that was an interesting new therapy. And then this was my favorite one. This was a therapy designed very much for a specific mutation in P53. That's a gene that's frequently mutated in colorectal cancer. And they built a small molecule that binds selectively to this P53 mutation at the 220th amino acid. And they gave it to 29 patients. And they actually observed responses just giving this drug in 5 of the patients. And in fact, once a phase 1 trial works by slowly escalating the drug amounts. And so, of course, when they were giving the lowest doses, there weren't responses. But when they got to the highest dose cohorts, there were 3 out of 10 patients had partial remissions, and all of them had stable disease, at least stable disease. So this is another really interesting study. So just to quickly switch gears to prevention, which is really important, but I didn't think there was a lot of big studies that came out about this at this particular ASCO. But there was a study that made me think that, underrepresented populations, or Black and Hispanic populations have a lot of mutations that just aren't recognized yet by geneticists. And I think that represents a gap in knowledge and potentially underscores the historical underrepresentation of these patients in clinical trials and could affect them clinically. If it's not known as a germline variant that affects risk, we won't pay attention to it. And so I think this highlights an ongoing need to mitigate the associated healthcare disparities. I found the design of this study to be very interesting. So just to pause for a second, look back and just make a general comment about overall impressions from ASCO 2022. I think significant ground was made in the MSI high patients. But unfortunately, that's the low-hanging fruit. We need to do better with the other 85%. Cell-free DNA tests are becoming more relevant to treatment decisions, and there are some exciting novel therapies emerging in early phase trials. I would also say that, again, it's becoming more and more clear, left-sided, right-sided cancer are different diseases. We have to think of them that way. I'll stop there and invite any additional questions.
Thank you, Dr. Cannon. We have one additional question. If in remission for 5 years, then reoccurrence, will the new tumor have the same mutations that the primary had?
Okay, great question. This is something we all think about a lot. The short answer is not exactly no. But unfortunately, in a lot of cases, the true answer is there probably won't be a change in the mutations that matter, with a few exceptions. In other words, if you're hoping that, over time, you'll suddenly have a new mutation that has a great targeted therapy, that unfortunately very rarely happens. The mutations that are targetable, that are driving the cancer, we call them truncal mutations, and you just don't get new ones that are targetable. Unfortunately, sometimes you will, like in the case of RAS, have mutations that make it less easy to treat the tumor over time. So that sort of just furthers the notion that the genetics of a tumor become less favorable typically the more it's treated. There are exceptions to that, but as a general rule, really favorable changes a long time after the initial presentation are not common.
Thank you. And we just had a few other questions come in. What about treatments based on CMS classifications? Will there be targeted treatments based on that?
On CMS, I might not know what that acronym means. CMS classifications? If the writer wants to write in what that acronym stands for.
Okay, I've got one beyond that as well. Any thoughts on de-escalation based on MRD, like a dynamic, for patients that need to make those choices before more studies complete?
Yeah, I do. That's a great question. Yes, there wasn't a great abstract about it. Sort of was a randomized trial testing this exact question. But the question's basically asking is, if you're doing that liquid biopsy, I'm calling it a liquid biopsy, but those tests that detect tumor DNA in the bloodstream, in the plasma, if you're doing those tests serially during someone's treatment, and you see that it's disappeared, can you relax a little bit with the therapy? And yeah, I think in practice, that's what we're doing to some extent now. If we're finding that, there's no measurable disease in the cfDNA, we may be more inclined to move into maintenance or no treatment at all for a time. Whereas if we see that they're on a light treatment and that number is rising, we may decide to escalate treatment in stage 4 disease. Similarly, in stage 3 cancer, if someone was planning on just getting 3 months of chemotherapy, but we see their cell-free DNA is high, we don't have evidence to back this up yet, but I think it is becoming more common practice to say, well, this person needs 6 months of chemotherapy because we've got to do everything we can to knock. There's a really high risk of metastasis here, and we've got to do everything we can to knock it out. So,
thank you. Oh,
yeah.
I'm sorry.
An emerging paradigm there, but not a lot of proof that we're doing it right so far. It's a new technology, and we're learning how to use this tool.
So the person who asked about treatment based on CMS classification defined CMS as consensus molecular subtype 1 through 4.
Okay, yeah, so kind of a signature. Yeah, I think that's far from being used as right now. I hope that someday that's used as a point of care, a decision-making tool, because I think it will be helpful. But of course, the practicality of getting the results, getting the predictive data for subtypes, knowing the implications of treatment for each subtype are a little ways away. So I don't think we're there yet, but I do hope that is, a part of the future.
Next question, and I know that we're getting down to the end of our hour here together. So this question is, on watch and wait, if ctDNA is positive, but the rest of the screenings are normal, is there a treatment recommendation?
So not a universal one. Obviously you could, the treatment sort of background really matters here, right? You may be, that question, if you're asking about a stage 3 patient that just had their tumor taken out and you see cfDNA, I think you'd be more inclined to give chemotherapy as an adjunct to the surgery. For the stage 4 patient that you're treating intermittently, yes, you may be more inclined to give to give treatment if the cell-free DNA is positive. But again, we don't really know exactly how to use these studies or how to use this tool yet perfectly.
All right, one more. What I have heard more commonly is MSIH, rectal cancer, being about 2%. What is your experience? Is MMR testing commonly done everywhere for rectal cancer?
Well, not everywhere, that's for sure. Yeah, I practice at a pretty large cancer center, and we have, I think, over 30 oncologists, and we have four that just do GI oncology. So at our center, everybody would get this test, and the 2% number, I'm not sure what that refers to. The estimates for what percentage of colorectal cancers have an MSI high type cancer range between 10 and 20% across the board. They're more common in right-sided cancers. Among rectal cancer, it's about 7%, but 2% would be too low. I've never seen any subset that's been that low.
You have time for one more?
Sure.
Okay, so this is from Mimi. I have stage 4 NRAS, BRAS, non-600 sigmoid colon tumor removed with mutation to liver and lungs. Is she right-sided or left-sided?
Left-sided. So if I understood that correctly, you said sigmoid colon at the beginning?
Yes, sir.
It said sigmoid colon, RAS wild type, BRAF wild type, and it has metastasized, I think is what she meant to say, to the liver. And yes, that would be in the more favorable subgroup as a left-sided RAS wild type cancer.
Thank you. That is all the questions that we have. I want to thank you for your time today, Dr. Cannon, and for all of the participants that were on the webinar today. Thank you.
Thank you.